Funding for this program was made possible in part by AARP, a nonprofit, nonpartisan membership organization leading social change and delivering value to people age 50 and over through advocacy, information, and service. Support for this program is provided by the Foundation for Excellence in Louisiana Public Broadcasting.
Hello and welcome to Louisiana Public Square. I'm Beth Courtney, President of Louisiana Public Broadcasting.
And I'm Robert Travis Scott, President of the Public Affairs Research Council of Louisiana. When the Supreme Court upheld the constitutionality of the Affordable Health Care Act last year, it did strike down a key provision which would have required states to expand their Medicaid eligibility or lose current Medicaid funding. Well, this decision gives states the choice to opt in or opt out of the Medicaid expansion.
Well, currently, 24 states have either approved or are leaning towards approving the Medicaid expansion. 13 states are unsure, and 13 states, including Louisiana, have said they will reject the federal dollars. And Governor Jindal says accepting the federal funds will lock the state into an inefficient program that will ultimately end up costing Louisiana more money. Well, proponents say the expansion will cover hundreds of thousands of residents at barely any cost to the state for the first 9 years. Tonight, we look at both sides of the issue as we explore Medicaid expansion, take it or leave it. With only weeks left in the legislative session, some lawmakers want to involve Louisiana in the federal Medicaid expansion that Governor Jindal has so far declined.
It's a huge, I believe, moral obligation, and it's certainly one that's deep-based within my own beliefs, that we should do everything we can to take care of those that can't help themselves.
Senator Ben Nevers is a Democrat from Bogalusa. Nevers is supporting amendments that would use the federal Medicaid expansion funds to provide private insurance to Medicaid-eligible residents, similar to a plan that Arkansas is pursuing. These actions will require a waiver, and the Obama administration has said that a limited number will be granted.
So it's very important that we get in on the front end rather than on the back end. So I would encourage us to move as quickly as possible.
The Medicaid expansion available to states through the Affordable Care Act will extend Medicaid eligibility to individuals making up to 138% of the federal poverty level. For an individual, that's someone making $15,420 a year. For a family of four, $31,812 annually. According to an analysis by the Public Affairs Research Council of Louisiana, there are somewhere between 291 and 419,000 uninsured adults in the state who would fall under the increased eligibility standards. The feds will cover 100% of the benefits for participating states from 2014 to 2016. Its cost-sharing drops down to 90% by 2020. Governor Jindal has said that Louisiana will not participate because it commits the state to future costs and an unsustainable program.
We want to assure that people have good access, good quality services, and we're passionate about making sure that that occurs, we don't believe that Medicaid expansion is the right way to do that we have other options that will be more flexible and will work better for Louisiana.
Kathy Kleber is the interim secretary for Louisiana's Department of Health and Hospitals, or DHH. Her department oversees the state's Medicaid program. Kleber says whether the Medicaid dollars cover an Arkansas model or a traditional eligibility expansion, there are too many unknown financial risks. She says DHH data estimates that 41% of Louisiana's population would end up on Medicaid under the expansion.
And long-term liabilities of having that many people in Medicaid, that percentage of your population in Medicaid, I think for the state and certainly for the department is a really high risk. in terms of what they will cost both taxpayers, but also cost in terms of our future generations and where their income is going to go in the future.
Under a DHH analysis of the Medicaid expansion, a low-impact scenario could save the state nearly $368 million over 10 years. But the report also predicts the expansion could cost Louisiana $1.71 billion over the same time frame. Among the reasons, DHH estimates 171,000 newly eligible individuals with insurance would drop their coverage in favor of Medicaid, adding to the state's costs. Healthcare provider reimbursement rates would have to increase to meet increased demand.
Right now, and for the larger community hospitals, the ones that are in Baton Rouge or Shreveport or Lafayette and New Orleans, the reimbursement rate is about 60 cents on the dollar of what it costs to deliver the care. And this is not a sustainable model for any healthcare provider.
John Matticino is president of the Louisiana Hospital Association, or LHA. He says that most of Louisiana's hospitals are receiving less reimbursement from Medicaid today than they did in 1995. Despite this, the LHA favors Louisiana's participation in the expansion as another option for the uninsured to gain coverage. Besides, Matticino thinks it is inevitable.
It may not be next year, but I think we will eventually expand Medicaid, and I think, when we do, we need to make sure that there's proper reimbursement structure to keep, hospitals and physicians and other healthcare providers in a position where it doesn't cost them to deliver that care.
Dumping thousands of patients into a system that's really not working well, I think, for physicians or for patients really right now, isn't a responsible thing to do.
Dr. Philip Roseman is a cardiologist and president of the Shreveport Medical Society. He says that problems with the state's current Medicaid health plan program need to be addressed before considering any expansion.
The Bayou Health Program has made it more difficult in dealing with Medicaid patients and the Medicaid system. It is, by and large, an administrative nightmare.
Under Bayou Health, Medicaid recipients select one of 5 health plans to manage many of their Medicaid health services, but this variety complicates things for providers.
The lack of standardization in the plan, multiple different plans, multiple ways to try to deny claims, different insurance companies, these all make it very much harder to deal with people who have Medicaid.
Dr. Roseman says while there may be no consensus in the physician community about the Medicaid expansion,
I think where we all agree is that we need more insurance coverage for those from low income. There's no doubt about that. Where we disagree is that believing that the current Medicaid system is a system that can handle that.
The expansion offer comes at a time when the state's Medicaid program is still recovering from cuts of $551 million in 2012. The bulk of these fell on the state's charity hospital system. The Jindal administration is gambling on a series of public-private partnerships at several of these hospitals to close the gap. No matter how any current legislation pans out in the legislature, Matticino says it's important for the state to consider all of its options.
I think we definitely need to begin to at least have the conversations with the federal government to look at how we can bring some of those dollars into the state and how we can cover people. I mean, we've got a lot of uninsured people here in Louisiana that we need to get covered somehow.
Well, joining us in our studio to discuss the Medicaid expansion debate are residents from the greater Baton Rouge area. We're also joined by members of 100 Black Men, AARP, and the Legislative Youth Advisory Council. Well, welcome to everyone. LSU's Public Policy Research Lab surveyed over 100 citizens on tonight's topic. Among the survey responses, when asked their opinion of the Health Care Reform Act that was signed into law in 2010, a total of 48% of respondents have an unfavorable or somewhat unfavorable impression of the legislation, while a total of 27% have a favorable or somewhat favorable opinion of the bill. 25% were unsure. When given the choice of whether or not Louisiana should participate in the expansion of Medicaid, 49% of those surveyed said it's a good idea, while 36% said it was a bad idea. 15% were uncertain. Asked if they were more likely or less likely to say Louisiana should expand Medicaid if it meant the state might spend more on the program in the future, 53% of respondents would be more likely, while 36% would be less likely to support the state expanding Medicaid coverage. 11% were unsure. And when asked their opinion on a current bill in the legislature that would accept the federal Medicaid expansion dollars but use them to provide private insurance for lower income adults, an equal percentage of those surveyed, 43%, both support and oppose the measure, while 14% are unsure. Well, let's start at that point. Based on what you know about the federal Medicaid expansion, should Louisiana reject these federal funds? Should we take part in this particular expansion? Bobby, why don't we start with you there?
Well, my personal opinion is that yes, I think that Louisiana should participate in the Medicaid program for a variety of reasons. One of which would be the working poor who have a hard time making ends meet to start with, and then whether or not they either choose not to or can't afford to purchase insurance. That's one side of it, the working poor who would be covered under Medicaid expansion. But maybe too, another piece of it is employers who might be taxed because we refuse to accept Medicaid expansion, and then they've got to pay a penalty. And the return on investment to the medical community, I mean, all of those things ought to be considered part of our deliberations in accepting Medicaid expansion.
Weighing in some good points, Bobby. How about you, Marcus?
Yes, I do believe that we should take part in it. You know, America's always been said that we're the country where dreams are born. So if I don't have the basic necessities of health care, how can I pursue those dreams? You look at entrepreneurs all the time. They may not have the means to go out and get a Blue Cross plan. So this is another way that they can go out and get health insurance.
How about that? Well, does anyone disagree with these two gentlemen that maybe this is a little bit too much? Betsy?
I'm one of those people that the question is, what does it really cost us? We don't know. There are so many unanswered questions. And one thing that I know is that everything costs more than you really think it will. So how do you balance the needs for desiring better outcomes with public health? Because certainly we do have weaknesses there, but at what cost and who pays it? And then again, I mean, are you really solving the needs that are providers being covered? Because as the doctor from Shreveport talks, there, fewer and fewer accept Medicaid patients. Does that mean there's a larger group in the pool? And then of that pool, fewer physicians to treat them?
Right, and we often look at this subject and say, well, the state would be getting all this federal money, so the state should take it. But let's remember the federal government is the federal government too, and that's our money as well. So that's another way of looking at this. Cheryl, you on board with all this?
Yes, because I think for the reasons that other people have already expressed, and because this is, the question before us is, we're going to pay it one way or another. People who don't have insurance wait till they get really sick, they go to the emergency room, and they cost us money there. So why not get people the care that humanly they need and deserve, and we end up with healthier population? I mean, it just doesn't make sense any other way.
There are a lot of aspects to this Affordable Health Care Act. Do any of you know of a circumstance or someone who would be affected by all this expansion as we're going into it, or would be infected by the law? How about Paul and Nancy?
So absolutely. We have a 32-year-old son who was diagnosed with rheumatoid arthritis at the age of 7.
Now, I should point out that you two are married,
We're
right?
married. We are.
And do you actually agree on this subject?
We do.
I'm sorry to hear that. I was hoping for a little marriage quarrel here. But
we'll try to make it more interesting, but we live with the reality of having a family member who has a serious illness, someone who's uninsurable. And I can greatly appreciate what many of the citizens in our state face who don't have access to care. And, I agree that we are going to be paying for it if we do not expand Medicaid. As a taxpayer, we're going to be paying for Medicaid expansion in the states that do expand Medicaid. So why wouldn't we also expand our Medicaid and be able to benefit from that expansion?
Yeah, and Ernie, do you know anybody who is impacted by this, or
yes,
yeah?
Several employees, at the university who have extended family members, because one family member actually, the wife got sick, bankruptcy, lost everything because of health care. And the question that I have is, what would it cost us not to do it? That's the biggest question, with the compassion and making a difference in people's lives. A healthy employee, a less stressed employee, is a more productive citizen.
But doesn't it create a kind of entitlement program and balloon an entitlement program, so large? I mean, can we really afford this in the long run? Isn't there maybe a better way to do this? Has anybody thought that? Is anybody here? How about you, Sandra?
I think that's part of the issue here. We're being told by this administration that they don't want to expand Medicaid, but we're not given an alternative. There are no plans other than creating these private partnerships with state hospitals and driving uninsured people, again, as the lady pointed out, when they're sick enough to get to a hospital, to the wrong end of the care spectrum.
Mm-hmm. And we'll have a gentleman from DHH out here in just a moment, and we can engage him on that very question. But Bobby, you want to jump back into the
So the issue is, over 3 years, the feds pay 100%, right? And then 90-10 for some period of time. Our healthcare system, I mean, our health outcomes in Louisiana are some of the worst in the country. We're closing public hospitals. We've chosen not to go to expand the Medicaid program. We're going to let the federal government do the health care exchange. Why not take the money from the feds, take it for 3 years, pay our 100%, and then work on whatever the plan is that's best for Louisiana? We got 3 years. Otherwise, we're going to continue to pay. The money will come here and go to other states.
Well, there was a recent study out that from the New England Journal of Medicine that raised some questions about whether Medicaid really was providing a good quality of care. We can maybe get into that later. But Jean?
That article in the New England Journal of Medicine that you just referred to, does indicate that they compared people who had Medicaid with people who were uninsured, and found that people who were uninsured died at a 6% higher rate over a period of 1 year's time, just from the simple fact the only difference in the population was that some had Medicaid and the others had nothing. But the other thing that puzzles me, if I may continue,
yeah, go ahead, please.
Okay, is that the Legislative Fiscal Office has, which is, I'm told, a very objective body in terms of the data that they use, has estimated that over a 10-year period that there'll be savings, ranging anywhere from $185 million to $510 million, or some, ballpark figures. And the Department of Health and Hospitals, their own estimate over a 10-year period is that it will save the state general fund $367 million.
Yeah, well, but I mean, the State Department has different scenarios, and one of them is actually would cost a great deal. And part of this is based on an issue of trust with the federal government. I mean, they say they're going to pay 90% of the costs after 2020, and I guess the question is, how many of you trust the federal government to stick with that over the long run? Because we'd be signing up for a big bill in the long run in the state. Earl, do you trust the federal government?
Well, I think it's a matter of pay me now, pay me later. One of the things, by getting people who are uninsured in the medical system, is that you're providing preventative medicine. Mm-hmm. For example, a person who has hypertension does not, if it's untreated, it leads to renal failure. Renal failure leads to dialysis, which is very expensive. So either we're going to pay less on the front end or more on the back end.
Well, that's all the time we have for this portion of our show. And when we return, we'll be joined by a panel of experts to further explore the Medicaid expansion debate. Welcome back to Louisiana Public Square. Tonight we're discussing whether or not Louisiana should expand its Medicaid program as offered through the Affordable Care Act. Well, joining us now is our panel of experts. Joan Ruff is a member of the AARP National Policy Council and its Board of Directors. AARP is a membership and advocacy organization for people age 50 and over. AARP is in support of Louisiana participating in the Medicaid expansion. Calder Lynch is the Policy Director and Senior Advisor to the Secretary for the Louisiana Department of Health and Hospitals, or DHH. He has participated in shaping DHH policy priorities with emphasis on Medicaid delivery and financing reform. DHH is opposed to Louisiana's participation in the Medicaid expansion. Karen DeSalvo is a physician and current health commissioner of New Orleans. She is a former president of the Louisiana Healthcare Quality Forum and vice dean of health policy at Tulane School of Medicine. Dr. DeSalvo supports Louisiana's participation in the Medicaid expansion. And joining us from Seattle, Washington is Michael Tanner, a senior fellow with the Cato Institute. The Cato Institute is a libertarian think tank headquartered in Washington, D.C. Mr. Tanner leads research in a variety of domestic policies with a particular emphasis on health care reform, social welfare policy, and Social Security. Welcome, Mr. Tanner, all the way from Seattle. Although you're usually based in Washington, is that not right?
That's right, the marvels of modern technology.
Okay, great. Well, good to have you here. Well, before we go to our studio audience and hear their questions, I first just want to pitch a quick question to each of you on the panel, and I know you can each speak for 20 minutes on this, but just give me your highlight number one reason why we should or should not participate in the Medicaid expansion in Louisiana. We'll start with you. Ms. Ruff.
Well, thank you. And first of all, I want to thank you for inviting us here and to have this great discussion. AARP has always believed that individuals, regardless of health status or income, should have access to health care. And we believe that Medicaid, health care expansion through Medicaid will, in fact, help us get down that road. Ultimately, it's a people issue, because by not expanding Medicaid health care coverage, you are denying health care to those who need it and are most desperate for it. And to say that someone who is making $15,000 a year, 138% of the poverty level, is able to afford health care is erroneous. Those are the individuals who really need it, and for Louisiana residents, it's very important that this group is covered.
Well, thank you very much. Mr. Lynch, how about you?
Thank you, Robert. And I want to thank the studio audience as well. I'm looking forward to the discussion tonight. The Department of Health and Hospitals is concerned primarily about the long-term sustainability of our Medicaid program in Louisiana, and looking at our estimates of as much as 41% of our population being enrolled in Medicaid, what the long-term liabilities are, what the uncertainties are of what the impacts of choosing to expand Medicaid would be on our state, what we would have to do in our current program to ensure access to both the expanded individuals as well as those that are currently enrolled, could end up costing our state as much as $1.7 billion over the next 10 years, which is very concerning to us. We believe there are more efficient and effective ways that we can serve the needs of those that will continue to be uninsured in our state, which is why we're focused now on strengthening our safety net system through the public-private partnerships at LSU, which are already yielding great results here in Baton Rouge in enhanced capacity, additional ability to perform surgeries, provide services, clearing backlogs of pharmacy medications, and improving the way we deliver care in that system today. And that's our focus on using our dollars more wisely.
And Dr. DeSalvo, you have a lot of folks in New Orleans who would be impacted by this.
Well, we do. You know, expanding coverage to the Affordable Care Act for Louisiana is a great opportunity to not only improve the health of the working poor, the backbone of our economy, the people in service industry, construction, people who are in the service industry. This is a chance for us to really bring everybody in and improve health, but it also has significant economic impact. And the opportunity to do that, where there's going to be federal dollars supporting it to the degree of 93%, where in the first few years we're going to have full federal support and be able to really expand our opportunity to get people access to care is really unprecedented. And I think we ought to take advantage of it as a state, because it will save lives, it will save money over time, and it's the right thing to do to really improve quality of life and overall health for everyone.
Great. Well, Mr. Tanner, you've seen a lot of states dealing with this. What's your top thought on the subject?
Well, of course, it is very expensive. As you've heard, it could cost as much as $1.7 billion over the next 10 years for Louisiana taxpayers. And that's only if the federal government keeps its word on its full payment. And already, as part of the fiscal cliff negotiations, the Obama administration briefly put on the table the idea of moving to a blended rate, which would only be a 70-30 match rather than the 90-10 match. So the federal government, we have a little bit of a budget problem in Washington. I don't think you can count on them to keep going. And even if you do spend all that money, you're going to get very little bang for your buck. If you look at the Oregon double-blind study, they found no significant difference in health outcomes between people on Medicaid and people who are uninsured. Basically, they found that being on Medicaid didn't do you anything in terms of improving your health status. And finally, we should note that about 70 to as much as 180,000 Louisianans would actually be pushed off of private insurance and into the Medicaid system if the expansion goes through. That means those people would actually move from private insurance, which provides them good health care, to a Medicaid system that provides them inferior health care. Those people would actually end up getting poorer care if the expansion goes through.
Well, very good points, and thank you very much. We're going to go to our audience now and get some questions from them for our panelists. And Ariane, you had a question that maybe there's a third way of looking at this.
Yeah, so can any of the panelists envision a scenario where the Jindal administration would agree to implement federal policies in the state of Louisiana?
Well, let's let Mr. Lynch take the first shot at that.
Absolutely. And as I work for the Department of Health and Hospitals, we consistently and constantly are looking at federal programs, regulations. We are in a regular communication with our federal partners about ways that we can implement programs in our state that make sense, the ones that fit within our mission and our values that we want to move forward with. When we look particularly when we're talking about Medicaid expansion, some of the things that we've been interested in are looking at potentially limiting the expansion to 100% of the federal poverty level to coincide with the implementation of new exchanges, putting in provisions that would prevent, as it was mentioned by the previous panelists, people from voluntarily dropping their private coverage and moving on to Medicaid, as well as looking at ways of aligning those eligibility levels that we have today for children with the new exchanges so that parents and families can stay on one coverage product together. We think that there are opportunities to look at the benefit package, the way we do cost sharing in the program, the way that individuals access care that can make the program more viable. So far, we haven't seen a lot of flexibility from Washington.
And just let me jump in there, Mr. Lynch. You know, Governor Jindal at one time thought a Medicaid expansion of this type might be good for a demonstration project. He wanted to go to 200% of the federal poverty level. In Lake Charles area. And what's happened since then to change his mind?
Well, the Louisiana Health First waiver model, which I believe you're referring to,
right,
was a demonstration model that we proposed in late 2008 that would have provided the state with enormous new flexibilities in the way we designed the Medicaid benefit package and the way that individuals access care in that program. It was also designed to be budget neutral, using the savings that we got from moving to a managed care model to invest in expanding access to a more limited number of individuals statewide, only at 50% of the federal poverty level with the demonstration in Lake Charles. Since then, obviously, our state's budget picture has changed considerably, and the savings that we've achieved in our managed care program have gone to fill gaps. Ultimately, it would cost more to expand coverage.
And Dr. DeSalvo, do you see a third way, maybe, that this should be handled?
Oh, I'm always convinced that there's a way to find a solution that everybody can agree on. My experience with the state has been that they have been creative and flexible. In the New Orleans area, we have an 1115 waiver that provides primary care and mental health services on an outpatient basis to everyone below 200% federal poverty level who's eligible. We created that program, the local community, the local government with the state government and the federal government. So there was a compromise reached in many of the areas that Calder speaks of. So, for example, co-payment. And an opportunity to be more flexible in the kinds of care, so we're not just paying for actual visits or volume-based payment, as people say, but paying for coordination of care to really enhance the opportunity to follow people through the system. So we've done it in Louisiana, we've done it in New Orleans. I know that it's an option and possible, and I know the governor has done this with Bayou Health, and that the federal government has assured us that they're willing to be as flexible as possible.
Mr. Tanner, you've seen how a lot of states have handled this. Do you see that there's some effective third paths to make this successful?
Well, it's still playing out in a lot of states, so we don't know what the outcomes will be. We've seen that Florida, for example, has a very innovative approach in which they allow people on Medicaid to, in essence, choose sort of voucherizing the Medicaid program, if you will, and people can take that money and buy private health insurance with it. It remains to be seen exactly how that's going to work, but in the first couple of years, it has lowered costs and improved care. The problem is going to be whether or not the federal government is willing to be flexible. And so far, with a few minor exceptions, the administration has been in a take it or leave it mode.
Well, that was an excellent discussion. Thanks, Ariane. You really got everybody off on the right foot on that. And Alan, you have a question you want to shoot to.
Well, as the poorest and sickest population that we have in the country here, I can't see that we can't take some advantage out of all this money being spent. And there, you've already talked about a Plan B and a Plan C, and we just have to go forward with it.
Well, Ms. Ruff?
Yeah, and thank you for that question, Alan. It goes to a lot of the things that we're seeing here at our state office in Louisiana. We get calls from people who are in very dire straits, and they're asking for help. They're looking for help, and they're saying, what can you do to help? And they talk about their own personal situation or the situation of a family member, which affects them directly. They are in a situation where they have very severe illnesses, they can't pay for health care, or if they do pay for health care, they can't pay for food or rent. So that becomes a very critical issue to us as a society and to citizens of Louisiana. So I do think that we do need to come. This is a perfect opportunity for everyone to come together with some new ideas, with some thoughts, take all of the things that people are looking at. The important thing is to get health care coverage to everyone, and then look for a way to negotiate with the administration, and I think that's incredibly important.
And Dr. DeSalvo wants to control the costs in this. It's not like it's an open checkbook.
Which, there are proven ways to do that. I mean, I think that we can do both at the same time. I do believe that it's possible to expand coverage and create some flexibility in a program like Medicaid, which I always say is as old as I am, but isn't a learning being. And so we have to take the chance to take what we've learned for our community and create a program that's going to be less expensive, but also provide access to care for everyone. And remembering, too, as employers, that the last thing that you want, someone mentioned it earlier, was to wait until somebody's in the emergency department, because for all of us, we're paying for that in some way, whether it's through taxes or through higher premiums on our health insurance. But the employers also pay because the person misses work by having to sit and wait in an emergency department instead of receiving access to primary care and prevention at the front end.
Well, Paul, I don't want the Stitch couple to go home and you not have had a chance to say something that she did, so you jump in.
So I spent some time today looking on the internet, and I came across some statistics. Demographically, we have 4.6 million people that live in our state. According to the paperwork that I read, 20% of them don't have insurance. That's 900,000 people. Now, that's a lot of people without insurance, because we keep talking about the expansion of Medicaid, but really what we're talking about is basic insurance for people. Does DH&H or the state have any plans to do something with those 900,000 people other than send them to emergency rooms? Because right now, with closing all the charity hospitals, all you've really got out there is, that I know of, is these co-ops that you're doing with private industry, and you're sending these people through private industry.
I do want to address that. Thank you, Paul. That is a great question. And I do want to make sure we're talking about the numbers there, because those surveys, we see both national surveys that tend to overstate the number of uninsured. They undercount Medicaid recipients. Our own surveys here in the state, which actually reach far more people in their sample sizes, actually show there's about 653,000 uninsured adults in our state, our total individuals in our state. Only about Only 3% of our children in our state are uninsured currently. With the implementation of the new exchanges, a great deal of those individuals will have access to some form of subsidized coverage. So when you back those numbers out and you back out individuals that are over 400% of the federal poverty level, there's only about 214,000 individuals that will remain uninsured without a Medicaid expansion. And when you say closing charity hospitals, the only actual physical structure that's closed or will close is the Earl K. Long in Baton Rouge, and those services have been moved to Earl K. Long. All the outpatient clinics have remained open. A new 24-hour urgent care facility has opened about a block away from the old facility. In the rest of the state, our partners are actually going to come in and begin managing the charity hospital and expanding the offering of services in those communities, the quality of care that they deliver, the efficiency of the clinics that they run, the patients that they're able to see each day. So we see expanded opportunities for care.
Really drawn some interest on those. Ben, first to you, and then we'll come to you, Lynn.
With projections, Louisiana's been
in business for 200 years and can't project its annual income. I'm concerned about that. The Obamacare Act will move people either to a penalty, which will move them into the Medicare expansion. How do we know how many people are really going to come out of the woodwork if this expansion were to go ahead?
Well, before we go to our panel, Mr. Tanner, you've probably had that kind of question asked in the past. How do you know?
Yeah, that's a significant problem. What Robert Woods Johnson Foundation refers to as the woodwork effect. These are people who are currently eligible for Medicaid who just simply haven't signed up. They like what they call come out of the woodwork. When you start doing the expansion with the outreach efforts and everything that goes on, they may sign up. And many of these are folks who are insured today and who will drop out of their insurance programs and move into the Medicaid program. Louisiana doesn't get the 90-10 match for these woodwork folks. They go back under the old formula where you're paying 40 to 50% of the cost. I would also point out the best way to get people insurance is to get them a job. If you look at who's uninsured in this country, 40% of them are uninsured for 2 years or less. I'm sorry, for 4 months or less. Only 15% are uninsured for 2 years or longer. Basically what you have is the working poor who, when they lose their jobs, lose their health insurance. Well, if you add $1.7 billion in new taxes over the next 10 years, you're going to make it harder for people to get jobs, and that means it's going to be harder for people to get health insurance in your state.
Mr. Tanner, we have a couple of panelists who want to add on to your comments there. We'll start with you, Dr. DeSalvo.
Can't speak for every state, but in Louisiana, the typical person who's uninsured is a white man who works, like Calder, for example. But they're uninsured because the types of industry we have in Louisiana are predominantly small businesses or they're service industry, and they don't offer insurance, and the insurance is out of reach for employees. We have city employees who it's out of reach for them to purchase the insurance that the city offers. So we know that even firsthand. And having been a doctor and practiced medicine for 20 years in my community, I can tell you that the folks that we took care of, most all of them were working, and sometimes working multiple jobs, but health insurance was not offered by their employer, or they were kept under the amount of hours so that they would not be eligible.
Ms. Ruff, you also wanted to add in.
Yeah, I want to talk about those who are between 50 and 65. That is a group of about 60,000 that do not have health insurance coverage here in Louisiana, and those that are unemployed. And as we all know, if you are over 50, it is much more difficult to get a job. It takes much longer than if you are a younger adult. And those individuals do not have the finances to pay for health care coverage, and they're only waiting until they're eligible for Medicare. So one of the best ways, again, to get people back in the workforce and to have a positive effect on Louisiana's economy is, yes, to have jobs, but it's also to have healthy people who are able to work longer, who are able to stay in school because their health allows them to do that. And so from that standpoint, it is very, very critical that we do expand the health care coverage.
Very interesting. Now, Linda, you come from this from an interesting perspective. What have you got?
Well, I'm real concerned about the plan that Louisiana has, because we get all this data, we look at all of these reports, 41% of the people who are currently insured would jump back onto this bandwagon if it happened. But basically what I've read everywhere is that less than 60% of those who could did that. Now I'm real concerned because we don't know what the plan is. You know, you get a lot of information, a lot of different pieces of information, but we have no idea what the plan is. So if we're not going to expand it, and I believe that the partnership between LSU right now and the charity hospital system has used up about 60 to 70% of the budget for the whole state, which means that a lot of people are going to be looking for somewhere to go, and they won't have it. So it's a great concern, and I cannot for the life of me conceive of not wanting to insure a person who only makes $15,000 a year. When I retired from Georgia Gulf, I paid $832 a month to keep my insurance.
We're going to recruit you as a panelist next. Yeah. Did you have is there a particular question?
Well,
it sounds like this is aimed at Mr.
Lynch. What is the plan? Yes.
And I do want to address your question, and I think, though, that it's important to note that I don't think those that advocate for Medicaid expansion have the monopoly on caring for the poor or uninsured. There are other ways to deliver health care to individuals. I mean, as Robert mentioned earlier, we had a plan in 2008 that was very Louisiana specific and looked at doing different models of care, different models of delivery. Most of the guidance we've seen since the Affordable Care Act has passed would limit many of the things that we proposed or not allow them at all to qualify for the enhanced federal funding. Our options have narrowed considerably. The scope of decisions that we have to make about how we can do this is very small. There's very little flexibility. In our state, we are looking at a different way. We are looking at trying to expand access to care for what will be a smaller group of uninsured individuals in the future, and using the dollars that we invest in those programs more effectively. You mentioned the budget. Well, part of what we're doing with these partnerships is looking at ways to invest local resources more effectively, looking at how communities can better invest in the care that we deliver to the residents in those regions. There are opportunities across the state through these partnerships to be able to better leverage local dollars more effectively, and we think there is authority in our budget to do that, and there are opportunities out there in those communities, and we're working actively with those partners to achieve that now.
What was wrong with the Arkansas plan?
I'm glad you asked that question. The Arkansas plan has achieved a lot of questions and debate recently, particularly in our legislature. The Arkansas plan is really nothing new. It's using existing federal authority. And the problem is it puts significant requirements on states who want to use a premium assistance model for Medicaid recipients. You're ultimately paying for a plan that pays commercial provider rates, which are much higher. And then on top of that, the state is required to pay for wraparound benefits that maybe aren't covered in that private plan that are mandated by Medicaid, like personal care services, in-home services that are very expensive. And we also have to provide additional subsidies to bring cost-sharing levels for those individuals down to the level they would have been in Medicaid. It's Medicaid with additional requirements and window dressings and higher costs. And ultimately, the CBO says that coverage in the exchange is going to be 50% more expensive than Medicaid.
Well, Dr. DeSalvo, we've heard a lot of discussion here about plans and different competing plans. From your perspective in New Orleans, you're in a unique spot there. We all know that New Orleans is a unique place, even in Louisiana.
In the world.
What sort of plan would work in New Orleans, and what would you change about what we're doing now?
Well, the gist of what Calder's saying is that the way Medicaid pays for care, which is the way most insurance pays for care, is that if you are sick and I do something to you, I get paid as your doctor. The problem with the way we're structured right now in the state is that, for example, what Calder's describing, these public-private partnerships, will pay the hospitals, but it's not going to pay the doctors. So the doctors are not going to get paid under that model, which they would under expansion, and whether it's an Arkansas model or otherwise. The ultimate thing is this. Everybody has to have a way to pay for care so they have a voice and a vote in their health care, and they can be a partner with the healthcare system. The healthcare system then has to be able to be paid in a way that doesn't rank people based upon the type of insurance status. So you have to level that payment playing field. Arkansas model does some of that. Everyone gets paid. Your value is the same, no matter who you are with diabetes. And then you let providers build medical homes. You let them have health information technology. You reward quality of care and value of care, and not just doing things to people. Those models exist in the country and also in Louisiana, not only in New Orleans, but we have great medical homes across the state. So I think we can do a Louisiana way, but what we have to do is figure out how everyone gets funded. It's great to pay for the care of the hospitals, but we have to expand it to the entire continuum.
Mr. Tanner, it's a chance for you to jump in on this topic too. And by the way, is there any state that's really doing an absolutely terrific job at dealing with this without a Medicaid expansion?
No, I don't think there's a state that's doing a terrific job on health care reform. A lot of it has to do with the fact that the real problems in our health care system stem from the federal level, and there's limits to what states can do. But we should also make sure that we don't conflate different things. Our goal at the end of the day is for healthier people. We tend to say that healthier people is the same thing as having access to health care, and that having access to health care is the same thing as having health insurance. In reality, they are three different things. And if you only have a limited number of dollars to spend, if you have one additional marginal dollar to spend, there's no evidence in the academic literature that providing that dollar to pay for people to have insurance is the best way at the end of the day to get healthier people. Maybe it's to have community health centers. Maybe it's a public health campaign. Maybe it's something else. But it's not necessarily to provide them with health insurance or even necessarily access to a doctor that's going to get them at the end of the day to be the healthiest they can be.
Great. This is a great show. I can't wait to watch it. Brenda, you've had time to absorb all of this, and now we're ready for your question.
Yes, I sure have. And the question that's been going through my mind throughout this entire discussion, not only today, but over the past few weeks, and I heard Mr. Lynch speak of Louisiana values and concerns about what's going to happen 10 years from now. I'm very concerned about today, and how can we, what about your conscience in terms of some 300 to 400,000 people with no insurance, and you sit here and you talk about why you can't give it? It's unconscionable.
Yeah, I guess you're really bringing up the moral issue.
Yes,
Is that
I
what you're
am.
trying to,
Yes,
to
I
do?
am.
Who wants to take a shot at the moral issue? Mr. Lynch,
I mean,
you're
your
in charge
question
of
was
morality
directed to
all
me.
of a sudden.
Yeah. You know, I think we've done, as a state, we have a history of caring for the uninsured and the poor, and I think it's a very proud history. I think that our entire country has a healthcare system that is set up completely wrong. We spend more per capita on healthcare than most industrialized countries, yet we have some of the worst health outcomes. We expanded access to coverage for children in the 90s through CHIP. Now less than 3% of our children are uninsured, yet our rates of obesity among children have skyrocketed. As the previous panelist was speaking, just extending health insurance, people may consume a lot more care, and we deliver a lot more health care, but we don't seem to deliver a lot better health. And so that's only half of the equation.
Well, let me jump in there, because there seems to be a strong consensus that Medicaid has delivered better health for children. Is that not true? And I've heard DHH say this many times, and that we do cover a lot of poor children and that we're better off as a result. Is that not true?
I think it's great that we've done an amazing job of covering children in our state. I mean, for families, that's important for them to have that opportunity to have immunizations, to have those pediatrician visits. But we haven't addressed the issue of health in our population, which continues to decline. With rising rates of obesity, cardiovascular disease, heart disease. I mean,
but
these
children
are really
have been better
concerning.
off. Is that not true? Under this program over the last decade or so.
Certainly, they have better access to health care, but are they healthier? I'm not sure.
Okay. All right. Ms. Ruff?
Now, there is a correlation between income and obesity, which directly goes to health. And part of health care is education and understanding and helping families do the best with what they can. And it is a moral issue. It's, as I said, it's a people issue. And we as a society must decide whether or not we are willing to put in the money, the time, and the effort to make sure that every person has the right to the best life they can have, which includes access to health care. And that means that the best of health care is not going to the emergency room.
Well, I would argue that the money is in the system. We're just not spending it wisely.
Mm-hmm. Bobby?
Probably a question for Calder. There have been lots of numbers floating around, numbers of uninsured, numbers of with Medicaid expansion, and numbers without Medicaid expansion. Costs to implement a Medicaid expansion program. The governor's own projections or statements when he first stated that he was going to decline the expansion was $3 billion, and then that number came down to 1.2, 1.5, 1.7 billion. The Legislative Fiscal Office projected a savings over a period of, I guess, 10 years or so of maybe 300 million. One scenario of DHH's was $100, $200 million savings. Does DHH know how much money the feds would put into a Medicaid expansion in Louisiana, provided there's no cutback? How much they would send here, and if DHH doesn't do the expansion, where does that money go, do you suppose?
I told you they were going to gang up on you.
No, it's perfectly all right. And I think your preface to your question is an excellent point of just the inherent uncertainty associated with this. How much is unknown? How much is difficult to predict? I mean, the early estimates, we looked at many different factors. There's been things that have changed in the law, changed in the assumptions. When we look at the Legislative Fiscal Office and our own estimates and why they differ, one of the things that the Affordable Care Act did was change the standard by which Medicaid had to deliver service. It changed the definition of medical assistance so that not only do we have to pay for the service, but we have to ensure the provision of it. That opens the door enormously enormously to future litigation or future federal action that could require the state to increase our reimbursement rates to ensure that we have adequate provider participation. And when we do that, when we increase those rates, it's not just for the expanded population at the enhanced new federal rates. It's for everybody that's in the program today at the rate we only getting 61% participation. That's why there's enormous risk and costs associated with expanding Medicaid. And to the question about the federal dollars in our state, I think that there's no clear provision that says that our taxes go up or down based on whether we accept Medicaid expansion. We pay the same level of federal taxes regardless. The bigger question is it less money we have to borrow from China as a country? Can we afford this program at all? Is there enough money in the system today that if we redesigned it, we could provide better health and a better long-term sustainability for the program?
Let's give Mr. Tanner. Let's give Mr. Tanner a chance to jump in here, because Mr. Tanner, if you could write your own Affordable Health Care Act and truly make it affordable, what would you do? I mean, what would a good national health policy look like?
I think what we need to do is lower the cost of health insurance so that more people can afford it. And the best way to do that is to move away from an employer-provided health insurance system into one in which individuals purchase their own health insurance and become better consumers of health care. We know that if people are paying out of their own pocket, their own money, that they're liable to make better purchasing decisions, and that would lower the cost of health care for everyone. At the same time, we need to break up the health insurance monopolies by allowing people to buy health insurance from all 1,300 insurers nationwide. You should be able to go online, find the cheapest insurance company anywhere in the nation, and buy that policy. They shouldn't be, as insurance companies shouldn't be protected as little cartels by state law.
A good libertarian point of view there. Earl, how about you?
First of all, Mr. Calder, I'd like to thank you for your courage. But I'm somewhat befuddled. I mean, you have these great plans, these theories of how to fix health care, but yet still, by your own estimation, we have somewhere between 200 and 400,000 people uninsured. And I think you would agree that's a pretty poor track record. Now, given your history of having a poor track record, why should we trust you with the future?
Well, certainly, I mean, it's nice to meet you, Earl, and I appreciate the, perhaps if we get to know each other better, you can trust me better. This is a difficult issue for our country, for our state. I mean, there is not a clear path forward. The Affordable Care Act is a very large piece of legislation that is a fundamental change to the way that health care is designed, delivered, and paid for in our country. Is it the best path forward? I don't think so. People disagree with me. I think the conversation needs to continue. I don't think it needs to end here with the Affordable Care Act, with Medicaid expansion. I think there are better opportunities to move forward to deliver care in a more efficient way. And do I have all the answers? No, I don't. But I don't think that expanding Medicaid in Louisiana under this plan is it.
Yeah, and in New Orleans, you already have one type of waiver that you're utilizing there. I've heard that there's at least one municipality is trying to break off and do its own as separate from a state. Is that in the cards at all for New Orleans?
It's our program in the New Orleans area is just that. It crosses parish lines, and it's serving 60,000 people who are enrolled in the program, about half of whom are in Orleans Parish, and it's been a highly satisfying program, and it's been demonstrating that people will use care. I think that it's not realistic in the way that healthcare is financed in this state for us to break off, though we have not given up looking for options, because we do believe very firmly that we want to have a healthy workforce and we want people to have access. I might add this point about the risk, which sounds a little lofty, but this is not a country that shies away from risk. And we are taking an enormous risk with the lives of the people who are uninsured right now. And I believe the estimate that 680,000 people die in the state every year because they're uninsured, and I think that's too great of a risk to continue to take. And if we look at the financial benefit of availing ourselves, we are going to pay for it as a country. It's going to move forward. We should take advantage of that for Louisiana. There's probably $16 billion of new healthcare dollars that will come down across the 10 years, and just in 2016 alone, $1.6 billion new dollars, 15,000 new jobs. This is an economic opportunity model for us, whether you believe in the moral argument or not.
And what was that figure? You were 680,000 people die in the state?
680 people every year.
It's 680. I thought you said 680,000. I thought that was a staggering number, Sandra.
One of the concerns I have is that the model that you're pursuing with the public-private partnerships is partially built on continuation of the disproportionate share hospital DSH program. And that's going away over time. So the Affordable Care Act is eliminating that in favor of covering people, and yet we're pushing that in lieu of covering people. I just don't get the equation.
Right, and I think, to your point, the DISH program, there are reductions that were outlined in the Affordable Care Act. And recently in the President's proposed budget, he proposed delaying those reductions for at least another year. Remember, those reductions were put in place when the Medicaid expansion was mandatory for states. In the proposed rule that just came out from the federal government just this last week, the reduction in Louisiana for next year would only be about 3.5% of our allotment. We only use about half of our allotment today.
But if it starts reducing and we've got this commitment to these public-private partnerships, these limited partnerships, then all the rest of the hospitals will get nothing, and how many will close?
We don't anticipate any hospital closures other than they'll move it in Baton Rouge to the Our Lady of the Lake. We have enough money in our budget.
I'm not talking about public. I'm talking about hospitals out in the rural areas. I'm talking about Baton Rouge General that the patients have to go by to get to the lake. I'm talking about Lafayette General. How many of those hospitals will be?
And I think people are a little thrown by DISH.
Give us the quick. So DISH is disproportionate share hospital funding. It's a federal program that provides matched federal dollars to reimburse hospitals for care for the uninsured.
Right.
And we use that fund in Louisiana. We're the 4th highest DISH state in the country for our allotment, and we use that primarily to fund our LSU system as well as many of our rural hospitals in our state.
Right. So there's all kinds of federal money. No matter which way we go, there's lots of federal money that we're going to be used one way or another. Well, listen, I thank all of you panelists. This was just great. We've run out of time for our question and answer segment, but we'd like to thank the panelists, Ms. Ruff, Mr. Lynch, Dr. DeSalvo, and thank you, Mr. Tanner, out there in Seattle, for their insight on this month's topic. Well, when we come back, we'll have a few closing comments.
Well, Robert, certainly an awful lot of lingo that's confusing around this conversation about DISH and wraparound care and all this, and the whole field is complicated.
Yeah, but this group tonight, I think, made it more clear than I think I've ever heard it before. So I think it was a great job by everybody. So.
Well, we're going to have this conversation extending out into the future, and I think we'll be back probably on another public square.
Even though we're not jumping on board right now in Louisiana, the discussion will continue,
I think
I'm
it
sure.
will.
So.
Well, that's all the time we have for this edition of Louisiana Public Square. We encourage you to visit our website at lpb.org/public square. While you're there, take this month's survey, view extended clips, and comment on tonight's show. We would love to hear from you. And remember, you can get the latest updates on the current legislative session every night on Capitol Beat at 6:57 and 9:57 on LPB, and anytime on the web.
Yep, that Capitol Beat's great. You should watch it. And will Louisiana be able to fill the estimated 69,000 technology job openings it will have by 2018? And how can the state reverse girls' declining interest in the sciences? Well, join Louisiana Public Square next month as it explores STEM status, science, technology, engineering, and math in Louisiana. Well, thanks for watching. Good night.
Good night, everyone. Thank you.
For a copy of this program, call 1-800-973-7246 or go online to www.lpb.org.
Support for this program is provided by the Foundation for Excellence in Louisiana Public Broadcasting. Funding for this program was made possible in part by AARP, a nonprofit, nonpartisan membership organization leading social change and delivering value to people age 50 and over through advocacy, information, and service.